Okay, let's go ahead and get started. I want to introduce Jennifer Fernandez from Pathways Institute, across the bay, Oakland.
We're in the city, in San Francisco.
Oh, okay. So the sign-in sheet is going around. Everyone please sign in. And with much further ado, I will just hand it over to you. Thank you for coming.
Of course, thanks for having me. Very excited. So I'm here to talk about impulse control disorders, specifically compulsive shoplifting and compulsive sexual behavior. And just to give you a little bit of background about Pathways, we work from a sort of harm reduction philosophy that kind of looks at compassionate care, celebrating small incremental change, and helping the person learn from any relapses that they have. And this fits really perfectly with these types of behaviors because most of these people are definitely not going to abstain from shopping. And most of them don't want to abstain from sexual activity. So harm reduction just fits nicely into these sort of process behavior-oriented addictions or compulsive behaviors. And then we also use an integrated cognitive, behavioral, and psychodynamic modality to help the person understand their compulsive behavior and then give them some tools and techniques to help them prevent relapse. And I encourage any questions or comments as I'm speaking. You feel free to interrupt me at any time. Our referral process for the shoplifting program, a lot of them come through pretrial diversion from many counties in the Bay Area, San Francisco, San Mateo. And then most, well, I'm going to say all of the compulsive sexual behavior clients are self-referred. So most of them come to us seeking treatment, which is really good. Okay. I think I'll move on unless there are any other questions about our agency.
Well, how is it funded?
It's a private practice. It's fee for service.
So I'm having a little trouble hearing you.
Okay.
And you said all of your compulsive sexual behavior people come from where?
They're self-referred.
Self-referred.
They seek us for
Okay.
treatment, yes. Okay. Great. So I wanted to start out with the definition of compulsion versus impulse because they are used interchangeably in the field, in the literature, and even within our own program. So compulsion is an irresistible, persistent impulse to perform an act, right? And to me, that kind of has a negative connotation. You know, persistent, irresistible, it's compelling, right? Impulse, on the other hand, can be an inspiration, motivation, or incentive. Well, wow, that's really different than the connotation that I hear in our field. So something positive about an impulse. Okay, interesting. And then other things are propensity or natural tendency, other than as rational, right? So there's a lot of irrational thinking or emotions or behavior involved in impulse, right? It's sudden and spontaneous. So I'm curious, while I was preparing this, I thought, wow, I wonder if there's anything that I do that's impulsive that's positive, right? So I'm wondering from this group, is there anything that you do that could be, good or healthy or positive in some way that you kind of do without thinking?
Brush your teeth.
Brush your teeth, okay.
I think general random acts of kindness are often impulsive.
Exactly, right. So I thought that was just a nice little, reframe, because a lot, in this field, I think we tend to, attach kind of a negative connotation. And so offering that reframe, even for the client, might be helpful to say that, there might be some impulsive things that you do that are good, and to help reduce kind of that shame or stigma that they might be feeling. So just my little lure of positivity. So some other impulsive behaviors that people might engage in are shopping, cruising Facebook, right? That's whenever you're feeling really stressed out or anxious or you need to distract yourself, you're like, okay, I need to do something on the internet, connect in some way. Drugs and alcohol, of course, can become impulsive. Other internet use, watching TV, gambling. Are there any other negative impulsive behaviors that I didn't mention here that come to mind?
Exercising.
Or eating.
Right, food can become negatively impulsive.
You've spoken about sex. It's not listed there.
Okay, so a little bit on impulse control disorders in general. So these are some of the hallmarks, right? These are some of the characteristics of impulse control behavior. So first there's a tension to do something, right? So there's some kind of trigger that happens either internally or externally. that causes attention to build, right? When the person acts out, there may be some kind of relief or pleasure that is experienced. Another hallmark, which is really, really powerful, are guilt, shame, or regret. And these can be really paralyzing, even to the extent that it prohibits the person from seeking treatment. It causes isolation and just more self-destructive negative behavior. Another characteristic is a preoccupation about the behavior, so thinking about it all the time. You know, that constant rumination about engaging in the behavior and what it means to engage in the behavior, the benefits of it. Distorted thoughts that help justify the behavior. Oh, it's not that bad, I can stop at any time, or this is the only way I know how to cope. You know, this is the only thing that I know how to do, so I need to keep doing it for my survival, right? Another characteristic of impulsivity is an increase of the behavior, right? So it becomes sort of, the craving for it becomes insatiable the more that the person engages in it, right? So they need to do it more often to achieve the same kind of benefit, the same relief, or the same pleasure. There's a failure to successfully stop engaging in the behavior. So there might be many attempts that the person has tried, and they're just faced with failure over and over again, which then feeds back into this guilt, shame, or regret, right? When the person tries to stop engaging in the behavior, there may be some irritability, anxiety, or agitation that comes up, right? The behavior might be an attempt to self-soothe. It could be emotional state, it could be physical pain, it could be psychological pain. The person might engage in dishonesty, such as lying, maybe leading some kind of double life, right? The person may be engaging in illegal acts that put them even at further risk. And then engaging in this behavior is probably, when it gets to an extreme point, going to risk relationships and maybe even careers, finances, right? Okay. Any other questions so far? No? And most of this, I'm assuming you all know because you do substance abuse treatment, right? So this is kind of preaching to the choir. Okay, so causes and treatment of impulse control disorders. We're not really sure what causes an impulse control disorder. There is some, provocative evidence out there about genetics, but we're really not sure. What we do know, we don't have any causal evidence. We do have a lot of correlational evidence. So what we do know is, for example, people who sustain traumatic brain injuries to the temporal lobes sometimes develop an impulse control disorder, right? So there's some clue there about what might be going on neurobiologically. We do know that there's a high comorbidity with other axis 1 and axis 2 disorders. We know there's a high comorbidity with substance abuse disorders. We also know that early traumatic experiences can lead to impulsive behavior in the future. We know that overwhelming stress exacerbates the impulsive behavior. So if you're faced with, losing your job or disruption into one of your relationships, or we know that causes the person to act impulsively, more impulsively. We know that if left untreated, there is an increase in the severity of the behavior, so the person may continue to put themselves at more risk, spend more time engaging in the behavior, and kind of ignoring the other areas of their life that are not functioning correctly. The best treatments are a combination of familial, peer, and professional support is what we found. So if we can get the client in to do individual therapy, if we can get them to do one of our 16-week psychoeducational groups, and if we can provide some kind of couple or family consultation, we are seeing, anecdotally in our agency that kind of wraparound service seems to be the best approach. And if necessary, there can also be some medication. Yes?
The comorbidity, axis 1 and 2 disorders, axis 2 I think we're pretty familiar with, but there's specific axis 1 disorders that you see presenting more often than others.
Yes, what I've been seeing at Pathways is an extremely high comorbidity with depression and anxiety, similar to substance abuse. So there seems to be some mood disturbance going on. Not really diagnosable, there is an emotional instability. So a lot of the people that come in to see us for help don't know how to cope with emotions, right? So they're just very poor emotional regulation. But the highest comorbidity that I've been seeing